Okay, hi everyone. My name is Emily. I'm a fourth year radiation oncology resident, and today I'm excited to be presenting our project looking at the effect of same-day VMAT on resource utilization in palliative radiotherapy clinics using a radiation oncologist-initiated automated planning script. So to begin with a bit of background information, rapid access palliative radiotherapy clinics enable patients to access consultation, simulation, and treatment on the same day. Typically how this is done is with a parallel opposed pair or a POP, which is an unplanned field technique where we essentially have one beam from the front, one beam from the back, and we're treating everything in between. Now there is a different type of radiotherapy called VMAT, Volumetric Modulated Arc Therapy, and I'll see if I can get our animation here to play. So how VMAT works is now we have the linear accelerator, the gantry that delivers the radiation is going to rotate around the patient in 360 degrees as it delivers radiation. And it has these little lead leaves called multi-leaf collimators that are going to move within the field as it rotates, allowing us to get a more conformal distribution. And so as you can imagine, although VMAT can improve conformality by decreasing the dose to normal tissues and decreasing side effects, this plan does take a few days to develop as opposed to a POP that can be done essentially on the spot. And so many rapid access clinics are still using POPs or unplanned techniques for efficiency. So in February of 2024, BC Cancer Kelowna did successfully implement an approach to routinely delivering same-day VMAT in their rapid access clinics using an automated planning script that I'll refer to as TPAS. And essentially how TPAS works is 3 simple steps. The user submits the request, you await plan optimization, and then review the completed plan. And so now to walk through this is our radiation planning system. And essentially the radiation oncologist will submit a request in as little as a few clicks. The system will then optimize the plan, and while awaiting plan optimization, it's working on meeting a few specific goals shown here. And essentially what these values mean is that we want to ensure that the target is getting homogeneously covered to an acceptable dose. And with the Dmax, that's our maximum dose, we want to ensure that there's not a hot spot over 110% of the dose of radiation that we're prescribing in the target or otherwise. Once it's completed, the radiation oncologist actually receives an email with the clinical goals that have been met, and they can go on to review the plan. And in order for this to be a seamless and efficient process, we do have inclusion and exclusion criteria for the use of the automated planning script. So essentially, we're wanting to include patients that are having a anatomical body site treated that we would expect a clinical benefit of using a VMAT versus a POP plan. And we're going to exclude anything that could complicate use of the script. So things like requiring a 4-dimensional CT for planning, a pacemaker, or a prosthetic. So the objective of our study was to examine the effects of same-day VMAT implementation using TPAS on resource utilization and throughput in rapid access clinics. We designed our study as a retrospective resource utilization analysis, and we included a cohort of patients both pre-TPAS implementation and post-TPAS implementation. We collected baseline patient tumor and treatment characteristics, both from chart review as well as radiation plans, and we completed a number of data analyses shown here. Moving into our results, I'll start with our baseline characteristics. So the median age of our patients in both cohorts was around 70. The most common primary histologies were breast, lung, and prostate. The majority of patients received treatment to one site, and the most common site treated was the bone. The most common dose and fractionation used was 8 gray and 1 fraction, and we did see that the proportion of bone mets that were able to be treated with a single fraction of radiation increased from 66 to 81% between the 2 cohorts. Looking now at resource utilization specifically, in 2019, 213 patients were seen, with 92% of these patients receiving treatment to 249 sites, and in the 2024 cohort, 202 patients were seen, with 94% receiving radiation to 246 sites. In terms of the timing of treatment delivery, we can see in both cohorts the overwhelming majority of patients did receive treatment on the same day as both their consultation and their CT simulation or their CT planning scan. For reasons why a patient would not have received radiotherapy during the rapid access clinic, this was most commonly either if the patient was asymptomatic or if they had had previous courses of radiation and the tissue tolerance of that area had already been met. And then for reasons for a delay in radiotherapy not being delivered on the same day as consultation, this could include the timing of their systemic therapy or requiring manual dosimetry for a more complicated plan. Looking now specifically at TPAS utilization, so of all of the sites treated within the 2024 cohort, 78% of these were eligible for a VMAT plan generated with TPAS. And we saw that 60% of these sites did go forward with a TPAS-generated VMAT plan, with 85% of these plans being delivered on the same day. And remarkably, the median optimization time of these plans was only 12 minutes. So I have a few examples just to show the clinical benefit of these plans. So this is a patient with myeloma treated with 8 gray and 1 fraction. This plan had a median optimization time of only 9 minutes. And we can imagine now, if this was an unplanned or a POP technique, just how much more GI structures would be included, and we can imagine the GI toxicity that we're now able to spare this patient. And similarly, another patient with myeloma treated with 8 gray and 1 fraction, this had a median optimization time of 8 minutes. And again, if we imagine if this was an unplanned field technique, just how much more of the lung and the normal tissues would have had to be included. So moving into our discussion, I've broken this into 3 main points for today. The first is implementation and resource utilization. So same-day VMAT using an automated planning script was both feasible and implemented for routine use at a regional cancer center, and this did not lead to any scheduling changes that would have adversely impacted patient throughput and did have similar resource utilization compared to our historical data. Next are the rural and remote considerations. So using VMAT on the same day may have important implications in areas with either finite resources or to minimize time away from home for patients receiving treatment from rural or remote communities. And last are the benefits of automation. So using technology to improve efficiency with a modest change in resources can permit same-day VMAT, reducing normal tissue doses and toxicity. Our references. Thanks so much for your time. We're excited that this was presented both nationally and internationally in the last few weeks at Caro and Astro, and happy to take any questions.
Thank you for this talk. I work in palliative care, so it's really important to have access to radiation, but not so much that causes more side effects than the benefits. I'm curious, so it seems like overall very advantageous, but is VMAT in some way more expensive, or like why hasn't it been already accepted?
Yeah, that's a great question. I have an additional slide here just comparing the workflow. So essentially VMAT is a more resource-intensive plan. So when we're doing a POP, that's typically the radiation oncologist sets the fields and approves the plan, and we can kind of use our basic physics principles to think about how that dose will be delivered. Versus when we do a VMAT plan, the radiation oncologist does the contouring, it then goes to our dosimetry team and then to our physics team, and it has a more rigorous quality assurance process because it is a more complicated plan. So it's really the resources that make it a bit more intensive. So as opposed to a POP that we could set fields on and deliver within an hour, a VMAT plan, typically the patient has a CT simulation scan. They actually usually go home, and it takes a few days to a week, for example, to generate that plan with our physics team, and then they come back for treatment. So it's really trying to streamline that process. So when we do have patients needing palliative radiation, that they can have it urgently.
How do you plan to upscale this technology? I mean, this was done at a single site, single center, but with these benefits, what's kind of the future?
Yeah, that's a great question. So we've already started that process. We have spoken to other sites about it, and we do have some working groups going, looking at how it could be implemented at different centers as well. For example, starting with a single tumor site, how could we implement it? For example, just for lung tumors or just for bone metastases, and developing local protocols with the local physics teams, and then hoping to upscale from there. But it's been actually a really nice way to have collaboration between centers as well. So I guess essentially just with our multidisciplinary working groups, we do have radiation therapists, medical physicists, and radiation oncologists involved in those teams. So it's been, good to scale up that way.
Where is the program, the computer program housed?
Yes, that's a good question. So our radiation planning software is called ARIA and Eclipse. And essentially how this works is it's a automated planning script written by our physics team, and it's, for lack of a better word, almost like a plugin into that system. So now there's an area within our radiation planning system that you can navigate to, and then it's just a few simple clicks from there to send this down the TPAS pathway rather than the manual dosimetry pathway.
Oh, sorry.
Oh, yes. It's a good question. So I guess otherwise we would be setting a POP for these patients. So similar amount of time to an unplanned technique, but with the increasing use of stereotactic techniques and SABRE, we certainly have lots of contouring on those plans. So, but it does bring up a good point that by streamlining this process, as we move into more complex treatments in the oligometastatic setting and more SABRE, it does free up time to work on those more complicated cases as well. So.
I had a question. In terms of the workflow, do these cases require tissue, like diagnostic tissue to proceed? Or in some of these palliative cases, can you skip that step?
So I would say in the majority of our cases, we do have tissue to proceed. Having tissue, it doesn't impact how we deliver the radiation or the dose of the radiation, but often in the metastatic setting where it really impacts is the systemic therapy implications and what lines of systemic therapy a patient would go for. So for the overwhelming majority of cases, we do have tissue before radiating. Thank you so much.